the other hospitals in Beckley, and that is averaging out to about $310 per day, guys. We've got fairly low hospital costs per day in our area, but it's coming from negotiations. It's coming from working with the right physicians that staff those hospitals, that will put pressure on in the appropriate places for you, and who work with you to try to bring costs down. So you've got to negotiate your contracts. The contract with the IPA has already been negotiated, but now you've got to negotiate the IPA's contracts with the primary care physicians and with the specialists. And you've got to develop capitations. In our HMO, we work with 3 different capitations. The first capitation really is the rate per member per month that the HMO must get to survive. There's a rate that's developed, or a capitation, for each benefit plan. That becomes a multiplier times average contract size in order to come up with premiums that our packages are going to sell for. That's a very, very important figure. We have to monitor this monthly. We do a rate filing once a year that shows a rate increase every quarter. But we still review it every single quarter to see if it needs to change, what's happened that may require us to change the rates, even though we file a year in advance. The second capitation is the capitation that the HMO pays to the IPA. I don't pay fee-for-service for primary care. It's important that an HMO pass as much risk as possible off to the IPA for medical care. The HMO pays the hospital bill and our administrative costs of the HMO, and that's it. Everything else is paid by the IPA. Therefore, we pay a gross capitation that's been actuarially determined now based on actual experience, in the beginning based on an actuary's predictions about utilization in the area. We pay a gross capitation to the IPA. The IPA is a separate legal entity from the HMO. It's a corporation of physicians from varying practice styles. But then the IPA takes that gross capitation that we give them, and they pay a primary care capitation. These are the 3 types of capitation that are very important to us. Now, this primary care capitation is a very interesting capitation because the IPA has decided that it wants to place its primary care physicians at risk. There's some interesting stories attached to the negotiating of these kinds of agreements early on in the history of HealthWise. When I first talked to the physicians, to the medical director really, about a risk incentive program, he warned me, don't use the word risk with physicians. They take enough risk in their medical practice, they certainly don't want to take a monetary risk. And if they do, they don't want to know it, so don't call it risk. So I didn't. We called it a negative incentive. We called it everything you might imagine, but we never said the word risk. Then when we were having a site visit for our federal qualification, one of the feds stood up to the president of the IPA and the board of directors and told them he was impressed with the amount of risk that they were willing to take. And the doctors fell apart at the seams. What risk? We're not at any risk. What's this risk business? So we never use the word risk, but it is risk. The doctors get, if our base capitation is $450, let me start here, for basic primary care visit. If the physician has a subspecialty, we will pay an additional 70 cents per member per month for his subspecialty by way of recognizing his ability. Now, this may sound weird to you, but we're in rural West Virginia. If the physician practices in a hospital, he gets an additional $1.80 per member per month. I hope that adds up. For a total of $7. Now, let's say the doctor, he gets all of this, okay? we're going to keep 30% of that, not to let him have it. He may never get it unless he's one of the good doctors as opposed to the bad doctors, because he is at risk for this 30 cents based on peer review of his utilization. Now, that's another thing the doctors don't like to hear about, is that they overutilize or underutilize or utilize right on target or whatever. They don't like, they like to think that whatever they do is based on medical necessity and quality medical care. So we don't talk about that too much. We talk about them being over budget, on budget, or under budget. But it is utilization. It's just some of the little games that you have to play to get the physicians to modify their behavior, that's all. So, there are two things that can happen to this 30%. Once a year, we're going to decide whether or not to give this to the physician. Now, if his primary care utilization is on or under budget, if his referral expenses are on or under budget, then he may get all of this back unless. I told you earlier that the HMO pays all hospital bills, and we do. But we think the physicians need to take some responsibility for what happens in the hospital. So the HMO will take part of the premium each month, and we'll put it into a hospital reserve fund. We're going to use this fund to pay our hospital claims. Now, if there's money left over here at the end of the month, we're going to share that 50-50 with the physicians. So if they did not exceed budget or they were under budget, the IPA stands to get 50% of the hospital reserve. Lost IPA. It's going to go back over to the IPA, to the primary care physicians. Well, if they were over budget, they got a share in that too. Now, if they've been under budget on referral, and this 30% is still in its reserve, they can use some of that 30% because this for a year accumulates to meet half of that overrun. But suppose they didn't. Suppose this is all gone. That's still their responsibility. The HMO isn't going to give them any more money, because if we did, we wouldn't be solvent. So what can they do? Well, they then have to go and look at the individual physicians in the IPA and determine who the culprits are. And the IPA has the right to increase this withhold, this 30% withhold, up to 100%. And that's a nice way of saying you're fired. And that's one of the most important sanctions that the IPA has. It's money. Everything's tied to money. The only incentive here is money. I would love to be able to tell you that all of my physicians are idealistic and concerned about the cost of health care. They're not. Enough are that got it off the ground. That's it. The rest of it is tied to money. That is the incentive, the primary incentive. I'm about to use up my time, aren't I?
You got about 5 if you,
All
it's
right.
a reasonable way to.
Okay, just let me show you something real quickly, because most of what else you may have, I can answer your questions later. I've brought something that may be of interest to you, but I don't have enough for everybody, so you can share it or I can leave them behind. But what I have brought is an example of something that my IPA board uses in taking a look at one another. Group practices do this kind of thing all the time. I've got physicians in solo practice doing this.
Why don't you pass them out, because they've used
Okay.
financial statements that way.
Okay,
They may have
top-
to group.
What you
more
see on top are some simple bar graphs. Behind it, what you're going to see is a cost of panel report. The physicians in my IPA are interested in knowing what each individual doctor in the IPA is costing the organization.
Close, can you all get to them? You have to move.
Here's another
to
one.
see it.
I'll let you have mine. This,
How about,
okay, after you take
You
off
want
the
it
bar
up here?
graphs, this will show, there's a sheet for each primary care physician. Shows the various areas of cost to the IPA broken down, and then we put them on a bar graph against a budget line. This is just one tool that they have for taking a look at themselves to see, who are the good doctors and who are the bad doctors. Now, the good and bad doctors are terms that they use. They've come up with this. And they will defend their panel costs to the end. This has been one of the most effective tools for getting the physicians to modify their referral patterns. I did want to speak just briefly to utilization. Beckley, West Virginia has an extremely high utilization pattern. Probably it comes out of the funds experience, so that's what the doctors tell me. They lay all the blame on the funds experience. But the community rate for hospital utilization in Beckley, West Virginia is 1,500 hospital days per 1,000 population per year. Isn't that a nice thing to face when you got an HMO to run? We projected year one at 750, and everybody said you cannot do it, you cannot do it, it can't be done. We experienced 628 in year one. We are at 500 now. I think we're doing very well. The emergency room utilization was 1,700 per 1,000 population per year. We are down at 125 for ER. Let me tell you briefly how we did the ER because it's important. It's exactly what Glenn was talking about earlier when he was talking about accessibility, availability. We developed a triage nurse system. I stole it straight out of a group practice clinic. I interviewed registered nurses who for some reason can't be leaving the home right at the moment to work. They've got kids or whatever. We put some very sophisticated telephone equipment in their homes. They're available 24 hours a day to health plan members. They have a special number that they call when they want to talk to one of the triage nurses. The triage nurses keep a list of all of our physicians and where they are. The doctors call us if they go out to eat before they call the hospital. If they're on vacation, they must provide backup. We keep the list of who's covering for whom. The triage nurses do several things. One, they verify eligibility if somebody's out of the area. You've got to be close to your health plan members if they're out of the area. Most of them are in Myrtle Beach, South Carolina in the summertime. But they've got to be able to reach out to you. We put the number on the back of their membership card, call collect. If you have to go to a hospital out of area, have them call us, please. We will instruct them how to bill. We're also going to tell them what the level of coverage is, but the card says we're going to instruct them how to bill. The triage nurses do telephone screening, they give telephone advice, they give nursing care under the West Virginia Nurse Practice Act over the telephone. They have an ability to connect the member with that member's primary care physician, just like that, with no problem. And this is what sells shelf-wise, and it's what controls shelf-wise.
They're employed by the HMO.
By the HMO, yes.
Have you had any malpractice?
No. Well, we probably will someday, but none so far, none of ours.
What happens on that range I looked at on that chart, where somebody is, what happens to a person who's way over here?
It depends. That's simply,
If it's
you
kept
place a
up.
red light, take a look at them. It could be a new doctor, yes, the people on this panel. Simply means look at them.
These are all doctors that are looking at this data?
Yes,
and
all
calling-
physicians.
And all calling in, they're the ones that call in.
Right. The panel is the group of HMO members who select that doctor. See, with an IP model HMO, this is with the group, you simply select a physician. So the panel is no wrong.
Board or whatever?
I'm sorry, I didn't know what you said.
Board.
No, it's the patients who join the HMO. Like, if you're a physician and 1,500 of my HMO members select you as their primary care physician, then you have 1,500 on your panel. It's your panel. Okay, I'm going to leave some information for you here. We have a directory of all of our providers, the primary care physicians, specialists, pharmacies, hospitals, anybody that we contract with, we put them in a directory. We have a large member services department that works with our marketing department. And when someone enrolls, one of the advantages to an IPA is that your doctors don't fill up that easily as they do in group practice, because it's mostly people who already go to them who simply have changed the way their health care is going to be paid for by selecting the HMO. So the panels don't fill up. If it's somebody who hasn't established a relationship with a physician, they may want some assistance in selecting the physician, and we'll provide that assistance simply by asking them some questions. Where do you live? Which hospital do you prefer? These are the physicians that work at this hospital. And do you want somebody that listens to you a lot or somebody that does most of the talking? What kind of person do you like? Consumers choose physicians very often by personality traits, not by their skills, not by their skills. So we help them select if they don't have one.
What is the structure? Is HMO controlled by IPA?
Oh, no, we don't, well, we do, but no. Okay. Legally, we're in partnership with them. We contract with the IPA. But if you don't control them, you're in trouble. It's better be able to control them.
Yes, the IPAs, they just don't want to be part of the HMO, so they come to them.
They want to, IPA means Individual Practice Association, right? They don't want to give up their independence. They want to be able to stay in a small office, and they think, at least allow themselves to be fooled into thinking they haven't changed their practice style. They have to. They've got to modify their practice style for their work change and that. And they do, but they're by themselves, and they say they're not taking a salary, they're not, they're getting a capitation, and it can change each month by the number of people on the panel. But it certainly doesn't change depending upon the productivity with their individual patients, and how much lab work they order, etc. They just, many of them are opposed to organized medicine. I don't know what they thought they were doing with funds, but it's certainly organized medicine.
I have two questions. First of all, do you ever have a problem where you can pinpoint under utilization where
Yes.
physicians in the training
Both.
system?
Yes, yes.
Have you read-
Everything that we have that pinpoints overutilization will, on the other hand, pinpoint underutilization. What the IPA board is doing now, it has directed its peer review committee to, they're beginning to put everything on a bell curve. And anything that falls out, on either end of the bell is going to peer review for appropriateness.
On average, for a normal working, how much?
From us, well,
That's a
see,
typical thing.
yeah, it's very difficult because I don't know how much they get from their private practice, their solo practice. From us, let's look at it this way. If a physician has 250 people on their panel, which is a fairly good average panel size for year one coming into the HMO, then he's getting, if we take this example, right, minus 30%, which is what, 210. What's in that calculator? Because I can do this stuff in my head. That's only, $1,225 a month from a panel of 250, which is small. It's another advantage to an IPA. And let me tell you something that's happened to Beckley since the HMO came in. All of a sudden, Southern West Virginia Clinic, who many years ago had no difficulty attracting physicians into the area, and then all of a sudden did, now does not again. I get calls from all over the nation, from physicians who, have been talking to recruiters and have been told there's an HMO in Beckley. If you go there and set up practice, they're going to help you build your practice, and we do. We can easily build a physician's practice. Whether he comes in with a group, the administrator of Southern Virginia Clinic will call me and say, what do you need? What are you loaning? If you're needing, a gastroenterologist, if we're needing it because we're having to send too much into Charleston where it costs more, he'll recruit a gastroenterologist. Whatever it is we may be having to need. And then we can give him a practice as long as he's willing to do adult medicine, to do primary care in addition to his subspecialty. And we do a lot of that.
Controlling like levels of production, like when you're talking about over and all that. You have a certain requirement of activity.
Well, what we have are, we don't have a requirement for productivity, no. What we have are the various areas that we have projected budgeted amounts that can be spent by the IPA. Because once the IPA gets this gross capitation from the HMO, they're not going to get anything else. They've got to learn to live within a budget. And they remember that they have agreed with us, when we made our utilization assumptions, that this is what it ought to be. So if they can't stay within that budget, they're burdened. They've got to pay their bills. They're not our bills any longer. We do, we pass off 100% of the risk for all medical care to the IPA. This was a real advantage to HealthWise because HealthWise was able, in negotiating a Medicare contract, to get a cost-plus arrangement with Medicare. We're not on a risk contract with them. Everybody that we enroll under Medicare is a real nice enrollment. We're glad to get Medicare enrollments. We're at no risk at all. Because we pass so much of the risk off, to physicians and IPAs. Like I know I'm over.
Well, I think people will be able to ask you and Glenn now questions on a general basis. But what might I propose that in conformity with the suggestion that we take a 5-minute break right now? And I hate to push it, but we want to get in as much time with our visitors as possible, so try to get that going. Whoever you'd like to direct your questions to, or to the panel as a whole. So any way you want to conduct your discussion on issues that might have been raised so far.
I have a question. I wanted to ask you, assuming that probably the majority of people you work are men, physicians and administrators, how is it as a woman to come in?
Lots of them. Yeah, they are. Yeah, we have a lot of female physicians, surprisingly. Of course, they're all either OB-GYN or pediatrics. All of the administrators that I have to deal with are men. I've really not had too much difficulty with the exception of one hospital. The hospital I thought would be the friendliest to me was the Appalachian Hospital. Happens to have a male administrator who's very threatened by a strong female. And I obviously am in the job I'm in, not because I'm a weak female, but because I'm not afraid to take on male or female if it's necessary. But it's kind of fun. It doesn't bother me at all. I enjoy it. I usually know if I'm being given problems for that reason. And, I was a nurse for many, many years before I moved into administration to play games with physicians, so I can play games with administrators if necessary.
How many of your physicians that you work with now were in the area when you came in? Can you say, or have any of those physicians been drawn in because of your activity?
Yes.
I noticed you have a lot of what I think are foreign medical graduates.
Sure.
That's why.
Yeah, they're all over West Virginia. Lots of foreign medical graduates all over West Virginia. Yes, there are at least 3 physicians in the area that were drawn into the area because of our HMO. Well, at least to the point that they were looking at various practice sites. They had made decisions that they wanted a rural practice. I think the fact that there was an HMO that they could align themselves with helped them to lean in our favor, certainly from the way they taught. If group administrators are doing some physician recruiting, they will contact me and ask me to meet with physicians, while they're touring the area and trying to make decisions about whether or not they want to come in and practice. Probably about 6 of the physicians that are in our present group have come in new to the area since we began operations, and we have literally built their practices for them. There's one rural physician that's very interesting, I think. Practices in a place called Flat Top. Michael know where Flat Top is. It's one of the highest points in the state. Extremely rural. He's a family practitioner. When he got ready to come into the area, he talked to us. He, with the exceptions of the money that he gets from HealthWise, from his or the IPA for his capitation for HealthWise members, and the money that he gets for billing the UMW welfare and retirement funds, and a little bit of Medicare, we're all the money he gets. His fee for service practice, for the most part, is paid for through bartering. You know, the old time concept of bartering. He gets paid in chickens and eggs and labor and lumber and so forth.
That makes you very important to him.
Yes,
can
we're
imagine
very important to him.
To what extent, when someone comes to you, a very careful trade-off balancing act, do you say, we're going to kind of weight your referrals, we're going to try to give you a start here because obviously we have administrators
Right.
for startup costs.
Yeah.
You've got to kind of,
It
you
depends
want
on-
them in, but
Yeah.
you don't want to offend your other members.
Yeah. That's a good question. It depends on where they're located geographically. If they're coming into an area in one of our 5 counties that doesn't have a physician, it's very easy for me to say, we're going to give you a practice, we'll target our marketing. I've done this many times. We will target our marketing, over the next 2 quarters to employee groups in your area. Or if you'll cooperate with us, we'll come to your office site and hold Medicare enrollments. There are lots of things that you can do that won't offend the rest of the physicians as long as it's geographic in nature. So we do a lot of that.
How do you contact with specialists? How is their contract different?
How is their contract different?
Yeah, how do you pay them?
Okay, we pay them, when we began, we paid them their usual and customary fee. Then we began to see some patterns develop that concerned us. What we can usually see if we take a look at the specialist fees in the area, and we've just completed an in-depth study of specialist fees in our area. Physicians who have been in the area, 5 or more years, specialist physicians who've been at 5 or more years, within 5 or 6% pretty much are charging the same fees. The new specialists that have come in, who've not built a practice yet, are jumping their fees 50, 60, as much as 75% over what the physicians who have been in the area. I do not want to pay for them to build a practice, and I don't intend to. I've got to be very careful about antitrust laws. I can't be accused of price fixing. So what we're doing, we have 2 choices. I've just gone through this, and it's real fresh in my memory. I had 2 choices really. Since the IPA contracts with the specialist physicians, they should be the one that are determining what fees they're going to pay, but they cannot, as a group of nothing but physicians, price fix, or I've got antitrust problems. They can do this. They can say that they have completed the study of specialist fees in the area, and they've made a decision not to pay above what appears to be usual, customary, and typical in like specialties. That's what they're doing. Now, there's one other thing they could have done which would have been easier, but the doctors wouldn't hold to it, and that is my board, the HMO board, could have said, okay, IPA, we're giving you a capitation, and you've got to pay for specialty care for that. We're not going to permit you to pay more than this for specialist procedures. So it would have been fixed fees imposed upon them by the HMO, which is a board of non-physicians. And that would have been legal. There would not have been antitrust problems there. But, as up and coming as these physicians seem to be, and progressive, they're not going to let non-physicians tell them what they can and can't pay for something.
But this string of trade problems with the HMO and
No, because it's non-physicians doing it. There wouldn't have been any problems as long as it's non-physicians doing it.
I have 2 questions. The first is, I really would like to hear something about the relationship between HMOs and existing healthcare services like health departments that are already there. you know, what you do about patients who jump from program to program even though they're enrolled. How do you
Okay.
handle that?
First of all, the first thing you do is make sure they don't jump.
How do you do that?
Okay, well, you do. You can do it. It has to be done primarily through education and then later by, unfortunately, by example, you know, how you treat the member who does jump. When someone elects the HMO option, they have to pretty much stay within that plan or their service isn't going to be paid for under the plan and it's going to hurt them in the pocketbook. Marketing representatives themselves do a very positive sell, but they also, once they pretty much feel they've got their audience, they have to move into a negative sell, which simply says the HMO is not for everyone. You know, and they must stay within the parameters of the HMO, or they're going to be facing claims that they have to pay. They do that very strongly. It's also in all of their literature. It's in their contract. It's in the Member Services Handbook. It's in the rules and regulation of the HMO, which they agree to abide. And then everybody makes a mistake, right? Everybody is going to jump out of the plan once. And one of the things that we build into our rates is that knowledge. Everybody's going to jump out at least once. And because we want to keep good relationships with our members, we allow everybody to do that. And we don't tell them, you all get to jump out just once, but we behave that way. If somebody goes out of plan, they get a letter of warning from us. And we explain to them why they shouldn't have done what they did. If they repeat it, then they have to pay the bill. And they don't do that anymore. Oh, jumping out means that instead of seeing a plan physician, going to a plan hospital for care, going to a provider with whom we have a contract, they've gone to somebody with whom we don't have a contract. That means they've jumped out of the plan. They're out of the plan.
Well, there's nothing to stop a person from doing that if they want to take the responsibility.
That's exactly right. You're quite correct on that.
The second question I have is dealing with the composition of the population. I see from your little flyer, it seems like you got anybody on this list.
Right.
But historically, most agencies have more older people, more mothers, and more children. Are there any special drives to get middle-aged, especially black males into the system?
Okay. What all of us hopefully try to do who are operating an HMO is to try to target your marketing so that you get a pretty good cross-section of the community, so that your HMO community is pretty much representative of the community at large. However, it's important to keep in mind that HMOs are offered as a dual choice option through employed groups. Therefore, it's going to be the people who are employed, you know, in the area. Therefore, if you've got, for example, 8% male blacks employed in the general population, it's going to be, the offering's going to be done the same way with the HMO. Usually, we try not to enroll high-risk groups early on in operation because an HMO has to be able to, first of all, identify groups that are going to provide a high risk, and then try to bring them in at a time when the HMO can financially absorb the risk and spread it across their population so it's not devastating financially to the HMO.
Mr. Wilson, I know you had said, posed a question earlier, what can be prevented? Now listen, just a few quick things that just came immediately to mind. For one thing, and I realized what this project means, you know, what prevention and all that means, and I realized, but the thing that I like to bring up is why perpetuate something that I feel can be reversed, you know, something that I feel is being reversed. Why perpetuate it with this thing saying, well, educating minorities, you know, and going down into projects and getting them to change to health education has to work. But the things I wanted to list were, like, number one, negative conditioning. That that start out early childhood, heart disease, stuff like that goes, to overutilization of emergency rooms. I feel like something like that could be presented. 3, excessive absences and turnover in industries, through health promotion, wellness programs, and say 4, alcohol, drug-related illnesses, deaths, just some basic things.
I understand what you're saying, but, and I'm certainly not an authority on the literature, but I suggest to you that we do not yet have a program or data to show that we can very effectively deal with any of the problems you listed. They are serious, clear problems, no question about it. But until and unless we can really, over time, show that we have something going that effectively deals with those problems, then I think we do ourselves a disservice by saying it in the abstract, because employers and other government, other kinds of people have money for it, and we've, except for AA, the control or change behavior on alcohol use is very small, and that's its margin. Absenteeism is a cultural phenomenon, and then I, as a civil libertarian, have some unease about those with qualified behavior. That, I'm not sure we know how to do it, but that makes me very easy. So that I'm not quarreling with the general principle of health promotion. It's just that I think for the 30 years I've been involved, we talk about it, but we really are short of good, solid demonstrations that we can do something effective. And I think instead of promoting it in almost an abstract way, we need to really sit down and say, this problem we can deal with, this we need to find new ways. So we really have a solid of something that will work. Data are pretty thin in that area, of course. That's my problem. Then let me just make one other observation. We took, in Cleveland, $3 million of taxpayers' money, planned health maintenance for people who have very comprehensive range of medical care available. We thought we were very careful. We had social workers, psychiatrists, nutritionists, all kinds of people working on this. We started with people who had chronic illness, which presumably was managed. But we found that chronic illness runs along very closely with various forms of personal and family and social problems. Schools, problems with children, problems in the courts, all kinds of problems. These people were making it. And I must say to you, in all good conscience, at the end of $3 million in 5 years, I believe we did more harm than good. Because these people were making it in life, and no matter how careful we were, they began to understand the real nature of their problems. The Randolph family, they lived in Paris, so the wife couldn't take birth control, so the husband got drunk and came home, and the little kid had asthma attacks all the time. Well, when that all became clear, what we did was the man left home and abandoned the wife and children. And I could sit here all afternoon and give you case after case after case for weed. So I'm very, very sensitive to people who got what you and I would agree with bad health problems. I'm not sure what bad habit I've taken up to take my pipe with me or my scotch. I'm quite aware of the fact that both are not good for me. And I urge everybody who wants to just be very careful when you break that little shell that makes it possible for us to go on, and make explicit to the individual some of these habits that are not repairable unless we've got the authority to change the whole society, which we're not going to get. So I'm just urge very great little question about it. Look through that for 5 years, with 500 people. I can tell you, the evidence is very clear. And still it'll be better than we were, but we felt we were pretty good. And we made a lot of tragedy here. We created a lot of human misery. We wouldn't educate them. And we didn't tell them their problems. People are not dumb. They figure it out. It took me 10 years doing my Pat Nicolao lecture over here to get the American Cancer Society to finally accept the fact that we just didn't do it every year. When the evidence was very clear. In every other civilized country in the world was doing what we just started to do for 15 years. There's not a shred of evidence that prevalent loss smears every year will change the cause and age of death of females. On a general population, we go for the individual woman. Be careful. It's the individual. But not a shred of evidence that it's a real public health for a total population. So I'm not against it, just skeptical.
That ought to get some debate moving.
I'm a little bit concerned because what I hear coming out is the fact that you feel once an individual is given the opportunity to make a rational choice, he will duck making a choice. He'll make a non-choice without his health, say an extreme case, with your diet, the alcoholism, losing his weight, eating his weight. Am I making sense? It seems like my perception of prevention is getting information so that people can make informed choices about what they choose to do. Are you against that, or going out and screening everybody for glaucoma?
Oh, I have no question about screening people for glaucoma.
Is this the
That's pretty simple. The problem comes when the real behavior modification. People smoke and drink and abuse their children and their wives and their husbands for a variety of very complex reasons. And what we found was that as we tried to educate them that they really ought to quit drinking, we then stumbled into the problem that there was no sex life, and there was no sex life because they lived in a certain parish, and the mother lived, the wife lived in that parish, and she wasn't about to move, lacking the capacity to move the parish priest. We unraveled the family by education. That's what I'm saying. That's a very dangerous, for some it's very dangerous. By trying to get the man to understand that he ought to quit drinking so the kid wouldn't have asthma. Right? The child was coming into the ER for our evening clinic 45 times a year. That's where we began.
Well, then how do you approach something like that if you don't
I don't know. I don't know, but I want to be very cautious. I'm not here. I just want to, because we unraveled that thing. No question. The last record I knew, the lady was a prostitute for these two.
I agree with what you're saying, and that I've had an opportunity to read some literature on education. That was just followed on topic, I guess, a few years back. And there is a lot of literature, I think, to support the idea that just because people know that something's wrong with people, that doesn't change their behavior. So just teaching someone to do it. So maybe educating them is not the way to prevent something. And it seems that historically speaking, the only way you've been able to prevent certain things that have a big impact for a lot of the public health measures that came out that sanitation laws and all that. So those were broad sweeping kinds of measures. The thing that I wanted to comment on in terms of prevention, when you were speaking earlier, is I was thinking about chronic disease, which is seems to be a big thing these days, and I was thinking about the project that they had in Finland. I think that it's North Korea or something like that, something like that. Now, Finland is a different government structure there, which makes it impossible to do some of the things that they did that we couldn't do. But it seems like that's the kind of thing that it would take to prevent some of the problems that we had, because that wasn't just one little positions or just a whole bunch of things that went into that project?
Well, I think that, with the homogeneous population, you have the. Let me give you two clues that I hope somebody will pursue some year. From the group in Sioux St. Mary, we've now looked at the people who use a lot of medical care. And every year, 26% of the population won't go to Dr. Paul. About 10% of the American people use 40% of all health services. And that's what bankruptcy HMO is, $2 million. And we've looked at this population now over 20 years, and there's some persistency in their use. They don't have much of a disease process, they have a dependency. They really, as you look at the cases, case after case of their stomach one month and the headache the next month and the foot the next month, and it's the bane of every doctor and every healthcare plan in the country. We're doing some counseling with these people, which will break the cycle. For about 9 months, we have to have another shot of counseling to back off again with the dependency on the doctor. But very interesting. If the mother is a high user of care, the odds are 0.7 child. And if the father is a high user of care, it's only 0.6. And children in the first year of life will use care pretty much the same. It begins about the second year of life, in which the high user parents' children begin to go this way. Parents take the child in their own anxiety to the doctor and begin to set patterns of dependency very early. We're not finished with the data yet, so I'm really quite preliminary. The second thing I would suggest you look at is really prevention. We, in the Department of Pediatrics, were involved and are very much involved in child neglect and abuse. We ran an identical program of education on high-risk parents, high-risk mothers for neglect and abuse. The same, as near as humans can do it, the same educational program had a very significant impact on the women with their first pregnancy. Almost none thereafter. Same training program. The ideal time, maybe to educate parents, is when the woman's pregnant for the first time, presumably if the man's not been a father before, they don't really know what's going on. Under the disguise of educating about the baby, you might do a lot of health education. And I don't think we've done very much in HMO about really weren't looking at this 10% who uses so much. And a lot of people think the 26% who don't come in ought to be brought in. And I'm not sure about the new leave them alone, they're just genetically healthy.
So are you saying now then that the 10% who use the health services, 10% of the population that use them more than anyone else, or that they have, they don't have legitimate health, like chronic disease or something like that, but they have a dependency problem that's not really more physical health?
We use the value judgment, which I wouldn't use. They have a legitimate illness.
Well, I was trying to say that, but we're still not, you're still saying that they really, it seems to me that they really don't have any.
They don't have a biological illness. They do not, a significant portion of them do not have biological illness. As anthropologists would say, they have a sickness. Professionals talk about illness, the people talk about, we talk about they're ill, and we say sickness when we mean biological. And a significant portion of the high users do not have.
What kind of proportion are they talking about?
The data's pretty thin, and I would not want to cast the family jewels on a bet on it, but I suggest well over half. The data I've seen over the last 20 years. They're unhappy people, unable to cope. I'm sure that your HMO has some people that are, what is pain? One person's headache is a severe problem, and it's not much to others. We don't know what the difference is. And those are the people who are consuming our resources, and there is the opportunity for, I'm very critical of HMOs, IPAs and new practices. We've had this information, we've had it for 30 years, and it's very little. We could essentially solve the whole cost of medical care, maybe these people need to go talk to just a friendly advisor to help them cope, not change their life. Somebody you just go talk to about whatever drug is that name. We're doing that to say where you do extraordinary results. School people. You know the qualifications of the advisor? A woman has, by all we can tell, successfully raised children. That's the only training that's required. Please don't go to the university.
That's why, right,
Pardon me?
you're talking about your program for parents who do.
This is in Canada. I'm jumped. North Carolina, they did this with trained counselors and all of that. This was a high-level academic enterprise. We just took a high school teacher and a semi-trained social worker and a counselor down in this museum green. And you see, there's no required if they go to university. Because you'll learn too much. They do a good job when a doctor has a patient who's been coming in repetitively in the hospital a lot, all kinds of problems, simply refers that individual, sometimes the whole family, to the counselor, and they spend hours in all kinds of complex discussions about their problems. And if they need a psychiatrist or psychologist, they go get one. They're what we used to think the neighbor was. There's been a lot of experiences with this kind of limited demonstration where you can dramatically change. Just put a friend, if you will, about checking the friend.
Yes, I have a little bit of a problem with wondering if it almost sounds oversimplified to me though. And what is the age range of people that we're talking about? Is this a general, are we talking about all people in the population? We're talking about where do the folks that really do have high blood pressure, and I'm sure it's connected to all this, but the ones who do have multiple biological problems fit into this.
Oh, well, I'm sorry, you're quite right. These are people who have available comprehensive range of benefits with a well-skilled 36-doctor medical group with no financial barrier. These people have been evaluated and evaluated and evaluated. They are then sent to this counseling service at all age groups with all kinds of problems. And at the first sign of a medical biological problem, they are sent back into the medical care system, which is in the same building. They're right together. So that without clear medical workup, it's very hazardous. This kind of storefront operation. I'm sorry, you're quite right. It's very important. And the whole thing. And if there's any sign of biological problem, they're sent back to the medical system.
You have to understand too, the reason an HMO is aware of this, Glenn's pointing to this, in fact we should publish it, is that they have control, they have total knowledge, they have the picture up here. This is happening every day to people who are not in HMO. I mean, there isn't a small group practice in the world who doesn't know there's say certain women in the community whose husbands don't talk to them, who go right into every new doctor's office for 1, 2, or 3 visits. If it's a town like Raleigh, the Blue Cross Blue Shield knows, Prudential knows, and they never publish the data, that this is going on all the time. That's the kind of person the HMO picks up. So no biological, no diagnosis, yes, keeping this up. I mean, the system is full of it. It's just that they've got the full data.
But the HMOs have yet to do anything meaningful with it.
What do you do? What do you do if you find yourself in a situation with a patient?
Oh, well, you develop alternate services for them appropriate to their needs. And you've got to be careful that you're not treating the headache and the psychological problem as brain filler. You've got to be careful about that. You've got to get the physician very sensitive to, well, this person is in to see me 10 times. There's not much wrong. And I don't have the time or the skills to really sit and talk with them to figure out what's really going on there. Where do you get that community service? It's pretty hard to come by these days. And the good HMOs ought to be doing this, in my opinion. But I've lectured them too many times and they haven't heard me yet. First of all, if they're only economic interest, you really cut the demand on doctor services. Really very clear. You reduce the demand on doctors significantly. You don't need a nurse to do it, you don't need a psychologist to do it, you don't need a social worker. The only thing, now, there's at least 20 studies on this, a little bit of demonstrations now. The only characteristic of is the woman, not a man, the woman. I hope the judge is successful in his children. You know, they're-
I think this is all going back to what was happening 50 and 60 years ago in communities anyway. You know, in black communities, there was always the mother of the community that everyone poured out all the
Sure, grandma was over.
and they still do that. And we found out in health departments, in communities that seem exceptionally well, there's usually a strong network of this established. They've got some
It's like basically, it's just that interpersonal sharing, that phenomenon of like confession or whatever, being able to pour out what your troubles are to someone that you look to in that sort of way, a nurturing way or whatever the case may be. You know, what you're saying, a lot of what you're saying, I'm getting at. I've been involved with clinics on the West Coast who are all holistic oriented things, right? And and here, there's a whole community here in Chapel Hill that's a holistic community. It has a lot of alternative ways, neuro-linguistic programming. And they've got this other kind of psychotherapy, right? Now this is alternative medicine also. This is alternative ways that I know people in the community right now that are getting a tremendous amount of help from. And they're able to handle this. But I'm just saying that the medical profession, as far as what I'm hearing you say, is they're skirting around all these issues. You know, we have somebody that's, you know, pouring themselves into the medical profession that don't really need it. And they've got alternative problems. Even biological illnesses. There's people with biological illnesses that have these alternative problems. You know, have these other problems that maybe the doctor's not set up to cope with, or is able to help them with. So I see it. I mean, there's a whole harmony, integration issue here that it goes back to the holistic. That there's a spirit, mind, body connection with people, and I feel that a lot of times they're at odds. Their basic fundamental problems are at odds with their religion, with their faith, or whatever. They're at odds with their family life. You know, there's fundamental problems that are involved here, and I see that instead of skirting, you know, the medical profession seems to be catching on more and more. I said, well, gee, we're sending them to that mother person, right? Non-licensed medical personnel. I mean, in California, we used to have problems all the time. Nurse practitioners, it was hard to get them into our clinics. And see, it's coming more and more. I just see that, you know, that this holistic thing is, and I've, you know, kept up with it off and on for a while, and I'm kind of holistic traditional, whatever. That seems to me to be
The holistic
becoming...
medicine people who are likely to become another professional group. That would be my guess.
Yeah, probably
They'll
so.
become like neuro-linguistic. That the next they'll want fee-for-service buildings like that, like surgeons.
Wait, when you say skirting the issue with these physicians, and these physicians aren't skirting the issue on these 7 out of 10 people who walk in the door have self-limiting illness. What they're doing is they're taking that money to the bank. Okay, you got one drug that only sold behind the counter. It's got the same ingredients up to about 100 milligrams more. If somebody walks in, they give that to them instead of Robitussin for a cough or something like that. I mean, you say they're skirting it, they're making money off of it.
Well,
And it's shown that 7 out of
Seeing
10,
their opportunities.
7 out of 10 are self-limiting, and a lot of psychosomatic or worried will. And the fact is, these people making money on it, and HMO, so I think them a great latitude to cut into that.
But all these new groups seem to me, they just want to teach the action.
Oh, I agree. And what
See, I
Again?
suggest the HMO to set up in Raleigh. Anybody who wants to be an entrepreneur, I'll give you the key position, make a course in Raleigh Durham Chapel Hill. The premium needs to be about maybe $2 a month. The sole purpose of this organization is the person who subscribes comes to you, and you figure out, because there's lots of services available in the church. Million free health departments, social agencies, all kinds. You kind of become the glue that puts the pieces together for the individual. All you just ask the phone and direct people to the right place.
that exists on.
I know, but it has to be everybody. I'm pretty keen on this. You know, there's a badly needed service, it seems to me, to tie these services together, so that, you know, this all kind of unconnected. And I think only the time difference, in my mind, between the practice HMO and IPA HMO is as follows. The group says, here we know that this is what we have to do. We did organize our resources to take care of it. by and large in the traditional medical field area. The IPA, that takes upfront capital, no buildings, and recruits a critical mass of people that's probably an urban phenomenon. The IPA is trying to do individual practice without the upfront capital and changing the way medicine by putting it together as a group. But unless either one begins to reach out and deal with this 10% of practice and make sure that the people get what's appropriate at all of these is what's happening. It's just not going to work over time. If we can't somehow quit breaking people into little bits and pieces. I'm glad you reminded me of neuro-linguistic specialist. Pretty soon we'll have the left ear neuro-linguistic specialist, the right ear neuro-linguistic specialist.
I disagree with that.
Well, that's where we're going.
Yeah, well,
And people don't come in ears, they come in as people. And they need to come to places where they get what they need.
that's the whole reason for this movement, is they come in as people, not as separate units. It's the holistic movement is you're treating the whole person, and you're looking at, a lot of you looking at the core problems, not.
Some people might be economic purists instead of holistic purists.
Well, that could very well be, it's people's personalities.
But when they become bankers, and the bankers become the ones who are setting up the programs, then you break them into pieces.
Yeah, yeah.
Because more profit.
We're talking about the movement as it is designed.
I know, but I think you'd say that the movement, what he's saying is that you would typify as a movement becoming polluted with people, not on the same, not with the same dedication to the holistic concept.
Right, yeah. See, but instead of, when I look at it in negative terms, I don't see any reason to look at things like that.
You still on preventive? You wanted to? All right, good. Oh, let's roll. Go ahead.
I'm not sure which one addresses it.